I'm Yoram RUDY, professor at Washington University in St. Louis, the United States. And I'm also director of the Cardiac Bioelectricity and Arrhythmia Center at Washington University. Very pleased to be here. Fantastic workshop in a fascinating city, nicknamed by many as the beating heart of Europe. I arrived here 2 days ago, and yesterday was a fantastic day in the meeting. And my role was to give a lecture on the electrophysiological substrate that causes arrhythmias in the human heart. Over many years, 35 years now, we've been developing a new non-invasive imaging modality similar to CT or MRI, except it is intended to non-invasively image the electrical activity of the heart, cardiac electrophysiology. In effect, it's a mapping technique to non-invasively map the electrical activity of the heart without the need to introduce catheters or open chest with a sock and electrodes put on the heart. Totally non-invasive. And what I described were our findings in, first of all, post-myocardial infarction scar, showing that the scar can be identified by this method. In fact, it's the electrophysiological substrate associated with the scar, or what we call the electrical scar. It's recognized by electrograms that are fractionated, lower in voltage, and also have late potentials. We could both image VT, cardiac arrhythmias evolving around scar, and also the electrical activity within the scar, the common pathway of a re-entry circuit associated and related to, with this technique, to the substrate that we determine during sinus rhythm. In the second part of my talk, I provided examples of hereditary arrhythmias and associated substrate, in particular the Brugada syndrome and long QT syndrome, and showed that the Brugada syndrome, the electrophysiologic abnormal substrate, is limited and confined to the right ventricular outflow tract, and shows both abnormality of conduction and abnormal repolarization. In contrast, the long QT syndrome of three different types, type 1, 2, and 3, there are no abnormal conduction manifestations. Conduction is completely normal, while repolarization is very abnormal with pronounced over 100 millisecond prolongation of the action potential duration in regions of the heart, and very high and steep dispersion of repolarization that of course can be very arrhythmogenic. Unlike Brugada syndrome, this can happen in many different regions of the heart, and in fact varies even among patients in the same family with the same exact genetic mutation. So that, in a nutshell, is what I described this morning. Thank you.